Okay, good day everyone. So this is week 4, session 1 of Epidemiology for Hospital Administrators. So we will present today the two foundational pillars of the Philippine public health system, the Philippine Integrated Disease Surveillance and Response, or the PIDSR, and Republic Act 11332, which is the mandatory reporting of notifiable diseases and health events of public concern act. So by the end of this session, you should be able to describe PIDSR, its structure, and its role in both the hospital and public health settings, and explain the mandatory reporting obligations under this law, Republic Act number 11332, and the 2020 revised implementing rules and regulations. So it draws directly from the two legislations, the 2020 revised IRR, signed by the Department of Health, no, on August 28, 2020, and the PIDSR Manual of Procedures, although that was published way before the pandemic in 2014. So here's an overview. So we'll discuss what is PIDSR. And then the second one would cover the rules itself, the policy declaration, objective, and some important key definitions. We'll go into the different types of notifiable diseases. Not all diseases should be notified immediately to the DOH. So there are some important diseases that we should prioritize in terms of immediate reporting to the authorities. And in connection, the reporting obligations. Who must report, what forms, and particularly the timeline and procedures. The section 5 discusses the epidemiology and surveillance unit, or what you call the ESUs, the structures, the specific functions, and their role in the city, municipal, and even the provincial levels. The 6 would cover disease response activities such as quarantine, isolation protocols, and even the management, no, in the hospital setting, in the public health structures that are available, and the main role of the Department of Health. We'll also discuss some penalties if you don't follow these rules, because all rules have some certain penalties in which one fails to act upon it will have a corresponding punishment, so to speak. And finally, some important forms that are used, no, as part of the procedures in reporting certain notifiable diseases. So let's look at the main overview. So PIDSR is, again, the Philippine Integrated Disease Surveillance and Response System. So surveillance is the foundation of all public health action. So without it, we cannot detect outbreaks, respond to emergencies, or even measure the impact of our interventions. So PIDSR is the official nationally mandated mechanism for our surveillance. So it has these 4 important characteristics. First, it is systematic, meaning there is a collection, analysis, and interpretation of outcome-specific health data. It is integrated, wherein it unifies case-based and event-based surveillance across health system levels. It is actionable, meaning this would be very important for timely dissemination in specific agencies or specific localities, wherein in turn they should respond by doing prevention and control measures, no? To avoid the increase in incidence of these diseases. And this is compliant and aligned with the World Health Organization international health regulations. And we will discuss that in the next session, not in today's lecture. So again, there are 2 important pillars would be the case-based surveillance, meaning you report individual cases using these specific forms. We will discuss also this later. And event-based surveillance, meaning there's a rapid detection of unusual health events by informal and unstructured sources. So both formal and informal means of reporting certain diseases, no, to the government. So before going any further, so let us anchor ourselves first to the legal definition, because this is a part of the law. And this was based on the 2020 revised implementing rules and regulations. So disease surveillance is defined as as I mentioned, no, ongoing systematic collection, analysis, interpretation, and dissemination of this data for planning, implementation, and evaluation of not just public health practice, but also policies also within the private health institutions, such as private hospitals. So note two keywords here, which is ongoing, meaning this is a continuous process. This is not something that is done occasionally. And its purpose is explicitly linked to planning and evaluation. So remember, surveillance, because of the data collection and analysis and interpreting it, we produce knowledge. And this knowledge should be used in order to drive particular decisions, no, in terms of uh, how do we practice and control uh, these diseases. So there are important surveillance systems that are used, no, and institutionalized based on the RA 11332. So the first one is the Hospital Sentinel Surveillance System. Second one is a Field Health Services Information System. And then the PIDSR. Fourth is the Community-Based Disease Surveillance System, the Laboratory Surveillance System, the Quarantine Health Services and Information System, and there are also others such as the COVID Kaya, the Health Facility Capacity Monitoring, and other Department of Health issued systems. But we will focus more on the PIDSR. So it operates through a 5-level reporting structure from the community up to the national level. So at its base would be the community and the health facility level. So these are the rural health units, hospitals, schools, workplaces, and even barangay health stations. So this is where the detection happens, where the patients first usually consult or present, and where the surveillance officer or the health worker first identifies a potential case. And then this now report goes upward to the local epidemiology and surveillance unit, or the LESU, which at the city or municipal level could also be called the MESU or the SESU. So it receives, it verifies and aggregates report from the health facilities, the community and health facilities that I mentioned. And then next level would be the provincial or the city epidemiology and surveillance unit. So they analyze data at a much bigger level because they compile all data from the cities and municipalities. So it now goes into the provincial level. You confirm outbreaks if there is indeed one, and support especially the smaller municipalities wherein their health system and their health infrastructure might be still uh, not as par, no, with the with the standards and it might not be in terms of the quantity and number might be sufficient, no, to respond to certain outbreaks or health crises. And then each provinces belongs to a particular region. So the regional epidemiology and surveillance unit, which is directly under the DOH Central, it provides regional analysis, technical assistance, and notifications to the main office. And then finally, the central office, which is the DOH Epidemiology Bureau, which handles national coordination, the international health regulations to the World Health Organization, and finally, policy issuances, no, based on the surveillance data that is gathered and analyzed. So again, there are critical timelines here. So there are one, the category one, which is immediate, meaning these are diseases that must be reported within 24 hours from detection. So it goes from the local epidemiology and surveillance unit, and then the regional, and then the epidemiology bureau. Category 2 diseases, meanwhile, is reported once a week, usually every Friday. And then epidemics. So if there is a suspicion of epidemics, it should be assessed by the DOH Epidemiology Bureau in a much shorter time. It should be within 48 hours. And any urgent events requiring the international health regulations notification must reach also the main DOH office within 24 hours. So let's look into the RA 1133-2 and the 2020 revised implementing rules and regulations. So this is not just a compliance exercise, and it tells us why surveillance is mandatory, who is responsible, and what happens when those responsibilities are ignored or not performed. So again, that's the RA 11332, the mandatory reporting of notifiable diseases and health events of public concern act. So there are four foundational pillars. First one is the state policy. Therefore, the state or the government commits to protecting and promoting the right to health and instilling health consciousness. Disease surveillance is the instrument that is used in order to commit for this health promotion by the government. National security, which is sometimes overlooked because the law explicitly recognizes epidemics and public health emergencies as threats to national security. They can undermine the social, economic, and political functions of the state. So this is not just a health issue. And of course, we all know the effect of what happened with COVID-19 in terms of those aspects, the social, economic, and the political functions. It is also the first line of defense wherein the DOH and its local counterparts fight a possible or an actual epidemic. This is very important because it gives the health workers and health offices a constitutional level mandate for their work. And then finally, the compliance with the international health regulations. It aligns its system with the World Health Organization, IHR, which binds us to global standards for detecting and reporting international health threats. So there are 9 objectives. So the first one is to continuously and develop and upgrade the list of nationally notifiable diseases with particular case definitions and lab confirmation. So definitely, there should be a unified disease definition wherein there is this presence of these clinical characteristics, signs and symptoms, and if there is a laboratory test that will totally confirm the presence or the absence of that particular disease or infection. Second one is ensure the establishment and maintenance, more importantly, the maintenance of these surveillance and response systems, both at the national and the local levels. The third one is you expand collaborations beyond the traditional health partners. So that would include also agriculture, veterinary, law enforcement, transport, hotels, and ICT companies. So the international container transport, because as mentioned, in the COVID-19 pandemic, it went beyond the concern of the medical profession and its allied health professionals. It also affected other aspects of life, and therefore we need these other stakeholders and partners that will assure also solutions in implementing certain policies by the government in order to prevent certain health crisis, or if there's a national health crisis that is ongoing or started, it would also help control and avoid the worst case scenarios. Fourth would be provide accurate and timely health information about notifiable diseases as an integral part of response to public health emergencies. The fifth one is you establish these mechanisms for collaboration with government health agencies to respond promptly to notifiable diseases, including contact tracing. And then you ensure also these authorities have statutory and regulatory authority for mandatory reporting, investigations, quarantine, isolation, and confinement. So, and then seventh would be provide sufficient funding, no, for all of those concerned, particularly the epidemiology and surveillance units, no, from the national down to the local level and the community as well. And then the eighth one would be it should require all entities, public and private, to participate in this disease surveillance and response. And finally, respect to the fullest extent possible the rights of people to liberty, bodily integrity, and privacy while preserving public health. So there should be a balance of the individual rights and, of course, the interest, no, of maintaining national health. So those are the main objectives. And then these are some of the keywords that are important. You can pause the video if you want to, and I won't give much further explanations. No, so these are self-explanatory in itself. So these are some of the words that we will be encountering, no, as we go along through this lecture. So, as we all know, this legislation bears in mind um, the problem of emerging and re-emerging infectious diseases. So, the the implementing rules and regulations defines these emerging and re-emerging diseases, which is a one that has not occurred in humans before. It have occurred previously, but only in small numbers and in isolated areas. So the first one, definitely COVID-19 would be the best example, no, prior to 2020. And then the third one would be have occurred throughout human history, but only recently recognized as a distinct disease. Fourth is are caused by previously undetected or unknown infectious agents. So again, COVID would fall into this definition. It could be due to mutant or resistant strains of a causative organism. So remember, we have mentioned the Delta variant, the Omicron variant. So, but even the flu strains, no, which usually have changing of strains annually. So, it can be also an example, no, of this particular definition. And then lastly, we're are diseases that were once major health problems. It declined dramatically, but are again becoming health problems. So a very important example here is the measles, particularly in the US. There's a re-emergence, no, of incidences of measles because of vaccine hesitancy and um, the rise, no, of the anti-vaccine mindset of certain individuals or groups in the US. So in our country, as I mentioned, COVID-19, SARS, which when I was still in as junior intern was almost gave us a scare, no, of things to come. The Middle East respiratory syncytial coronavirus or the MERS-CoV, and then the bird flu, dengue. There's still emerging strains that are being discovered, and there's also the reemergence of polio. Recently, in not just in our country but also in the other parts of the world. So the third section would be about notifiable diseases. So these specific diseases must be reported, how they are classified, in the criteria that determine what gets added or to remove from the list. So these are the diseases. No? So these are diseases classified into the mode of transmission. So the droplet spread, airborne, direct contact, a vehicle-borne, or the vector-borne, or usually from insects, no, or other animals. So the rule 2, no, of that IRR organizes these diseases, no, the five transmission modes of transmission. And then, so category 1 are the immediately notifiable diseases. So there are only 13 of them. So the first one is acute flaccid paralysis, adverse events following immunization, anthrax, again COVID-19, hand, foot, and mouth disease, human avian influenza, measles, meningococcal disease, the MERS, neonatal tetanus, paralytic shell poisoning, rabies, and as I mentioned, SARS. So this must be reported to the LESU, the local, the regional, and the Epidemiology Bureau within 24 hours from detection. So this even without the definitive diagnosis, not of the confirmation or detection. So even a suspected case, you should already notify the epidemiology surveillance units and the DOH Central. So you use here the case investigation form for this category 1 diseases. So there's a specific case investigation form that exists, no, for each of these conditions. And I think we can also add here the hantavirus. So we will also discuss hantavirus, but that would be also in the next session. But prior to because prepared this document way before, so these are just the 13. So technically there's 14 because of the latest threat, so to speak, which is the hantavirus. And then the category 2, as I mentioned, is the weekly, which is reported every Friday to the local epidemiology surveillance unit. It uses the case report form or the CRF. So there are 14 diseases, as I mentioned here. So while these are weekly diseases in terms of the reporting schedule, it does not mean you have to wait 1 week before acting on it. So like for example, dengue, you should already manage these cases because it can be easily be diagnosed, and time is of the essence, no? Especially infectious diseases. No? All of these infectious diseases has a time of the essence management that has to be performed immediately. So the categorization here is just an administrative reporting cycle, but the most important here would be an immediate clinical responses of these infections. So again, this list is not a fixed one. So that's just an updated and based on the latest information that I got from the DOH. The Epidemiology Bureau reviews and updates it based on the 9 criteria of inclusion and 7 criteria for exclusion. So these are the criteria that I mentioned. So again, it could be added if you can see here that the green box. So if it is of international or national concern, it has an epidemic or outbreak potential. This disease is being eliminated or eradicated. It is in the top 10 leading causes of morbidity and or mortality. It is a disease that causes large numbers of serious or long-term disabilities, or even large number of deaths in the population. Its characteristic, prevalence, and mortality is changing that could impact public health. It is the priority of the DOH. And finally, it fulfills the surveillance goals. However, on the other hand, the disease can be removed, one, if it is not already a public health risk or threat, it has no epidemic or outbreak potential, it has been eliminated or controlled, it's not part of the 10 leading causes of morbidity and mortality, it has low or no incidence of disability or residual complication, it has a low risk for mortality, and the prevalence, the characteristics is consistently low, and it has a minimal or no public health impact. So there is a case classification system, no? As I mentioned earlier, particularly category 1 diseases, you don't uh you don't report the case when it's just confirmed. Even at a level that the case is just suspected, you should already report category 1 diseases. Um, so what is a suspect case? So it is an individual, no, based on clinical and epidemiological criteria, um, fits, no, the definition by the DOH to that particular disease. So it is a starting classification. So this is you based on what you can observe clinically, and before any laboratory confirmation or testing is performed. Now, probable case is much stronger evidence. So you have already some initial clinical, laboratory, and other epidemiological criteria that the patient or the individual fulfills. But the difference here is that it has not yet met the full laboratory confirmation. But clinical evidence strongly suggests the presence of the disease. And finally, it's a confirmed case. So it uses a laboratory test, which is usually the gold standard for that particular disease, and it found to have a positive result. So a specific laboratory quest is required. No, it varies from one disease for another. It could be presence of antibodies, presence of antigen. So it depends on uh, the gold standard or the most accurate laboratory test used in order to detect the presence of that particular disease. So now what is the reporting obligations? So who must report, what forms to use, the timeline, and the procedures. So who is required to report? So this is part of Rule 6 and Section 2. So all of these uh, individuals and offices or even units are required to report. So definitely top of the list, us medical and allied health professionals. We have the obligation to report these notifiable diseases, health facilities and offices. So under the Administrative Order 2019-0060 and workplace and economic zones, educational institutions, so schools and even universities, and even the vocational schools are required also to report certain diseases. Prison, jails, and detention centers, because sometimes because of the crowding and the poor sanitary conditions of the correctional facilities, it could also be a source, no, of certain infectious diseases, and there could also be outbreaks that could happen uh, in this setting. Transportation terminals are also important. It could be a source also of spread, no, of certain infectious diseases. Hotels, dining and accommodation, the communities and barangay units, and then there's also the other government agencies, particularly those that provide health and emergency frontline services, like border control, customs, and other critical services. And then there's also the private individuals and groups, the professional societies, and the non-government organizations. They can also help in reporting certain diseases to the government. So these are the 10 categories. And they practically cover every individual in the Philippine society, because disease reporting is a civic obligation and it's not just a task of a health worker. So the forms, I think, yes. So there are three forms. So the case investigation form. So this is used for the category 1 or the immediately notifiable diseases. So it captures comprehensive data. So the detailed patient information, exposure history, vaccination, clinical findings, lab results, and the final case classification. If it is suspect, um, or even confirmed a confirmed case. So again, each of the category one diseases that I mentioned has its own disease specific form. And then the second one would be the case report form. So this is for the category 2 diseases, the weekly notifiable diseases. So this is a line list. So it captures, so unlike the case investigation form where it is filled up individually, the case report form is filled up multiple patients per single submission. So it records demographics, still reports clinical data, laboratory results, case classification, and outcome, but you submit more than one patient per submission or per document. And then finally, the event-based surveillance form. This is for non-health entities, workplaces, schools, communities, and non-government organizations. So they may not have the enough clinical expertise and knowledge to use the two forms, the CIF and CRF, because it requires some background knowledge in medicine in health in order to answer certain information in CIF and CRF. But this form uh, is much more friendly to those with limited or no medical background, and they can answer certain health events that might be of public health concern. And this should be reported usually within 24 hours from identification. So these are some of the examples. So now, what is the minimum data required for the mandatory reporting? So the following should be collected in all forms, whether it's the CIF or the CRF. So I won't enumerate them one by one. So you just have a look at it. Okay. Very important here. Yung particularly the address should be specific down to the smallest identifiable geographic unit. And then the current residential address. Definitely the date of onset or illness of symptoms. So history taking would be very important here. And definitely contact details. And then, although not mentioned here, travel history also during the last 30 days and other health conditions such as comorbidities and medical history is also important uh, um, to be filled up, no, in this CIF or CRF. So it's important here that patients are obliged to provide this information before availing of healthcare services. And if you, as a patient, provide false information, that constitutes non-cooperation, which has corresponding punishments, which I will discuss later. So again, how does from the reporting to submission, what is the process? So the first step would be detect either the detection or the diagnosis of that case. So either a health professional or that facility detects a notifiable disease or a health event. So you fill up a particular form. So if it is part of the category 1, you should report it within 24 hours. So you use the CIF. If it is only for category 2, you use the case report form or the CRA, and you should report it once a week, every Friday, to the local epidemiology surveillance unit. And then, once those forms are submitted, the local and the regional epidemiologic surveillance units acts upon it. It validates these cases and forwards it now to the national level. Which is per PIDSR protocols. So other important points here. So if there is no a local epidemiologic surveillance unit in that area, you submit it directly to any local health office. For suspect cases involving foreigners, no, in the country, whether tourists or expats or even already na, naturalized individuals. So you should immediately coordinate it with the Department of Foreign Affairs and the Bureau of Immigration. Patients must also provide complete and accurate data, as I mentioned earlier, and deliberately providing false or misleading information is a punishable act based on this law. And then, so definitely there's importance here of establishing the epidemiology and surveillance units. So the directive is that all local health offices in every province, city, and municipality must establish or designate ESUs and submit it to the regional office. So that should have been done during 2020, at around September, because 15 days from the effectivity of that law. And as I mentioned earlier, that was approved August 2020. So these are some of the requirements. So at least one disease surveillance officer and one epidemiology assistant. So they should be have particular training and knowledge about field epidemiology, surveillance, and response. Beyond staffing, there should be minimum resources that are required. So equipment and logistics, communication systems, transportation, laboratory, supplies and reagents for confirmation, personal protective equipment because some diseases can be transmitted to direct contact or aerosol. So um, definitely you need protection also to avoid getting that infectious disease as well, and health insurance also for this personnel. So again, these functions I've already I think in one way or another mentioned it, to verify notifiable diseases, provide timely information, you do disease surveillance and response, contact tracing, and then do what an appropriate response measures and facilitate capacity building in field epidemiology. So in the city and the municipal level, so again, data collection, analysis, gives feedback to health facilities and the leaders in the LGU level, give early warning to the concerned personnel, not just for the health workers, but also to the specific government agencies, particularly if there are diseases that exceeds epidemic thresholds, unusual trends, or new occurrences. They also investigate outbreaks. They also coordinate with other government agencies such as the Department of Agriculture, the Environment and Natural Resources, and other agencies wherein their assistance is needed if there is a possible outbreak and that needs to be investigated. They have to do control measures, data reporting also, and disease control. And then yung provincial, more or less the same. Okay? But very important here is one, since they are much larger in scale, they should alert um, municipalities, especially if these municipalities are initially not affected. So, for example, a particular city in that province has increase in dengue cases. Um, the provincial epidemiologic surveillance unit should also alert the other cities and municipalities wherein the dengue cases has not been increasing or rising at an alarming rate in order to already do some preventive and control measures to avoid um, increase in the incidence of these infectious events. They should also do urgent reporting, particularly the Category 1 diseases, to the DOH. It provides technical support to the smaller ESUs. Preparedness plan is also a specific function of provincial ESUs. And then the IHR notification. So that's part of also reporting it to the central office. And then finally, it support municipal and city surveillance teams through training and supervision. So how about disease response and quarantine? So this is the sixth section, which covers this very important step because detection alone is not enough. The system should respond. How do we manage it? So this governs the quarantine, isolation, and specific responsibilities of entities and personalities involved in case an outbreak or an increase of an incidence occurs in a particular setting. So I mentioned earlier quarantine and isolation. So quarantine, this means restriction of activities and separation from others of suspect individuals who are not ill. So that's this is the key phrase. Suspect and they are not yet ill. No clinical manifestations yet. No? So, but it doesn't only deals with the individuals that you quarantine. It could also be baggages, containers, conveyances, and goods. And even, for example, animals or pets, they are quarantined. So again, these are persons that doesn't have any symptoms yet. It could be they could be quarantined in the home or in a particular facility, just like what we did during the COVID. There should be a humane and dignified treatment in terms of doing quarantine. uh, these are not criminals. They don't even, it's possible that they don't even have that particular disease. So there should be a humanitarian consideration when we do quarantine in these individuals. Because remember, their freedom is somewhat restricted for a particular amount of time. They cannot freely to move around and do certain things because they should only stay in one particular area or a quarantine facility. Um, Law enforcement can assist the DOH, but it should not supplant DOH. So DOH should still be on top of the things doing the quarantine procedures. And failure to comply is also non-cooperation, which also have punishment based on this IRR. Isolation, meanwhile, these individuals already have the clinical manifestations of that disease. They're affected individuals, and again, objects, contaminated objects are also important because they should be separated to prevent the spread of the infection or contamination of those who are not affected. So it could be a suspected or confirmed case. Again, it could be home-based or facility-based. Um, but if the disease requires more stringent measures, definitely it should be isolated in a particular facility. It is authorized by public health authorities with a compulsory order or directive. And again, violation of these terms means non-cooperation. And then, what are some disease responsibility activities? So, um, definitely for the medical and allied health professionals, notifying the surveillance unit, and then even for those not part of the government health institutions, private practitioners should also report directly to the local health office. Health facilities, they should designate the surveillance units, comply with the surveillance systems, and use the appropriate form, the CIF or the CRF, to be submitted to the health authorities and allocate beds based on DOH requirements or directives that could be based on epidemic projections. Now, communities and general public must report health events or public health concern to the local health office within 24 hours. They should comply with minimum public health standards and ensure there's no acts of discrimination against these individuals with notifiable diseases, whether suspect, probable, or confirmed. And then the non-health entities are also involved here because they can also designate a unit that performs particularly surveillance unit functions within their area. And then reporting health events within 24 hours is a must. And they provide support for the workforce by giving transportation, lodging and stay, food allowance as needed. NGOs or the private groups can also do event-based surveillance and report these events if even suspected to the local health office within 24 hours. Finally, the transportation companies, um, they should also follow guidelines, no, in terms of transporting specimens, hazardous materials, personal protective equipment, medicines, and other commodities. And then, how about the core agency, which is the Department of Health? So these are some of the units, no, that are that have particular specific duties and tasks. So again, the Epidemiology Bureau, it rapidly determines control measures for both domestic and international disease spread. It provides specialized staff and logistical assistance, especially if there's an investigation of a possible epidemic, and it should establish or create this networking with other relevant government agencies. Um, the regional offices, it provides on-site assistance during these investigations. They should also have a preparedness and response plans that would be primarily based on the DOH directives, but there could be some unique response plans because there are some differences in terms of geography, the culture, uh, and even in other idiosyncrasies, no, or unique features in that particular region. And they also monitor compliance of hospitals with the PIDSR system. The Disease Prevention and Control Bureau, as you can see, as the name implies, it should give advice on recognition, prevention, and control of these diseases. It organizes a management community for if there is emerging and re-emerging infectious diseases, and they also be the the primary in charge, no, of Philippine Preparedness and Response Plan. The HEMB, the Health Emergency Management Bureau. So it is a coordinating unit and operations center for all health emergencies, disasters, and incidents with potential to become an emergency. So even, for example, flash flooding or during the times of typhoons, Health Emergency Management Bureau is activated because it could lead to a particular health crisis in a particular area, because, no, of the effects of these natural disasters. Health Promotion Bureau, they develop and implement strategic risk and response communication plans depending on the declaration of epidemic, no, by the DOH secretary, and in one way the president of the country. And finally, the KMITS, so the Knowledge Management and Information Technology Service. So it's best to have a organized documentation, an electronic system wherein all of this data can be stored, can be easily retrieved, analyzed, and it could be easily disseminated also to everyone concerned. So because this information will lead to the formulation of policies, plans, and other management task in order to control an outbreak or an epidemic. So as I mentioned earlier, the government declares a public health emergency. I think there are multiple times recently, besides COVID-19, wherein there is a declaration of public health emergency. And so, who can declare public health emergency? The first one is definitely the Secretary of Health. It has the authority to declare epidemics of national and international concern. So it could be like COVID-19, the pandemics, exotic diseases that is acquired locally, diseases that have international spread risk, epidemics associated with health service failure, or even epidemics at tourist facilities or international events. So critically, no LGU epidemic declaration for national concern shall be valid without the written affirmation of the DOH secretary. The president can also declare a state of public health emergency when a national concern epidemic threatens national security and immobilizes um, the government and even the NGOs to respond to this health problem. And then, in a smaller scale, provincial, city, and municipal health offices can also declare, in a way, public health emergency in their area um, due to a particular outbreaks. No? And only it is when supported by scientific evidence, no, from surveillance data, epidemiologic investigation, environmental investigation, and laboratory results. Again, the Secretary of Health affirms or it can reverse this local declaration of a public outbreak. So this oversight mechanism prevents premature or politically motivated declarations. Because remember, when a public health emergency is declared, the emergency funds, no, that is part of the national and local budgets can be released. And if there is so-called weaponization or abuse of the declaration of these emergencies, so these funds can be used for corruption purposes. So we mentioned the five modes of transmission. So there are minimum public health standards that can be used. So I won't belabor explaining it one by one because these are uh, being told repeatedly, no, in discussing particular diseases, no. But what is very important here would be hand washing, no, with soap and water or alcohol sanitizer. That is the most important aspect here. And for airborne diseases, in addition to droplet measures, increase ventilation in all settings that to reduce airborne transmission. No? Um, Either home quarantine or home isolation is also advised, and avoiding close contact with symptomatic persons. So now let's go to the punishment. So what are the legal consequences of failing to meet these obligations? So understanding this section is essential for everyone covered by the act because this involves nearly everyone, every citizen in the Philippines. So again, these are some of the prohibited acts. First one is unauthorized disclosure. So you should, because there's still a data privacy that's involved. No? The right to privacy is still somewhat should be invoked, no? In terms of doing surveillance and collecting data. So without the proper authorization, you should not disclose this data, especially if it pertains to a specific individual. Unless, no, reporting to the public health authorities is not a violation of this prohibition, which is part of the Rule 6 of this IRR. Tampering of records, so changing of the information, identification documents, movement passes, lab results, certificates, and documentations. So that's not allowed. Intentional misinformation, meaning, for example, you're a patient and you provide false or misleading information that is written in the forms. Also creating fake news, no? So especially in this time of social media, the false reporting of certain outbreaks or increase in number of cases of that particular disease. So in which there is a intent, no, to promote chaos, panic, anarchy, fear, or confusion. So whether it's in the social media, print, radio, television, so misinformation is not allowed. Non-operation of surveillance systems, because the key phrase again is there should be a sustained and continuous um, collection of data. Non-cooperation in reporting, meaning the failure to comply in terms of the time or the failure to grant the public health authorities access, no, to the information with regards to either confirmed, suspected, or probable persons, no, of that disease. Non-cooperation in response, so failing to establish the epidemiologic surveillance units, failing to perform specific disease response activities, and abiding minimum public health standards. Non-cooperation of deceased persons, so for those with that infection, if you refuse physical examination or giving of certain samples, you refuse also giving the much required information, or failing to comply with quarantine or isolation orders. So these are prohibited also in this IRR. And non-cooperation of contacts, because we want to avoid definitely spread. No, these contacts um, could either have acquired the infection or not. So they have the potential to spread, and therefore increase the number of cases of that particular illness. So failure to cooperate, no, with the the relevant agencies is also not allowed, and can face certain penalties. So these are the penalties. So a fine of not less than 20,000 but not more than 50,000, and or imprisonment of not less than 1 month but not more than 6 months. So which is decided by the proper court. So it also provides additional consequences, no, based on the status of the offender. So for example, foreign nationals, they are referred to the immigration for summary deportation after the service of sentence. So they, for example, the judge punished that individual with a 30,000 fine and a imprisonment of 1 month. After serving that sentence and paying of the penalty, that national is already forwarded, no, to the Bureau of Immigration. Licensed professionals, no, particularly health workers, so they are referred to the PRC to suspend, or worst case scenario, revoke their professional license, and therefore the right to practice, no, their vocation. Government employees, the civil servants, so um, doing the prohibited acts, the cases are also referred to the Civil Service Commission to either suspend or revoke their civil service eligibility. And then, how about the other facilities, corporations, and schools? The It's a chain of command, no? So the CEO, president, general manager, or the OIC can be personally liable. And then it could also affect their permit and licenses to operate, no, or to continue their function, no, as an institution or a company. So it it cannot be overstated that non-compliance um, is something that we should avoid, no, because that also helps in mitigating or minimizing a severe impact of that particular disease. And then I think this is the last one, would look into the details of the forms and surveillance tools. So again, there's are the specific case investigation and case report forms. So there's also the event-based surveillance forms. So I think this is 18, no, from what I uh, read just recently. So these are instruments that should fulfill mandatory reporting obligations. So familiarity of these forms is important, no, for those involved in the disease reporting. So again, the category 1, category 2, okay? And then despite being disease specific, these PIDSR forms share 10 standard sections. So first one is the disease reporting unit. So who's the one reporting? The regional health unit, the city health office, specific hospital, or even in the clinic. Section 2, the basic demographics, the name, date of birth, age, sex, and the address, civil status, and then the clinical data. So when did the symptoms began, um, the date of the first consult, and if the patient is admitted or confined in the hospital, what was the date of admission, what are the signs and symptoms, other clinical information, what is the diagnosis, any present, what are the complications. Fourth would be epidemiologic and exposure history. So we're looking now at the cause of why the patient acquired that infection or disease, because that's also very important in contact tracing and looking at the source, because controlling a particular source would help also mitigate the spread of that infection. Vaccination history is important, no? Especially for the vaccine preventable diseases. Uh, Specific laboratory data, whether it's for confirmatory purpose or other detection, no, of other manifestations of the disease. You classify the patient whether probable, suspected, or confirmed. And then what was the management and treatment given to this individual? So not just the medications. Was there a quarantine or isolation that was done for this uh, patient, no? Particularly isolation, and then the outcome, and if the patient, uh, the date of discharge of this patient. And then you have to also put in your details, no, as the investigator or the reporter of that particular form. So this part, Rule 8, governs who may process the personal data collected. So the rule here is the data collected from these surveillance systems is only performed by authorized personnel and shall be used for public health concern purposes only. So this is aligned with the Data Privacy Act of 2012. So again, these are the authorized personnel. So the municipal health officer, city health officer, provincial health officer, the regional epidemiology and surveillance unit head, and the head of the DOH Epidemiology Bureau. And then the Epidemiology Bureau has 5 specific duties. It should assess all reported epidemics within 2 days or 48 hours. It notifies the World Health Organization when event may constitute a public health emergency. Coordinate with other DOH offices for laboratory network, because this would be very important in confirming cases, no, of these diseases. Provide timely data to the public and disseminate the recommendations not just by the DOH but also by the World Health Organization. So again, in summary, so PIDSR is the backbone of disease surveillance, which integrates case-based and event-based surveillance across all health and even non-health system levels, from the barangay up to the national context. It makes disease reporting mandatory for wide range of entities, such as I mentioned, not just for health professionals, but also in other sectors as well. Category 1, again, should be reported within 24 hours. Category 2, every week. You use CIF for Category 1 for the case investigation form, and then the case report form for Category 2. For those non-health individuals or entities, you use the event-based form. Epidemiology and surveillance units are required at every level and must have adequate staff and resources, no, in order for it to function. And non-compliance, doing prohibitive acts are punishable. Again, with fines of 20,000 to 50,000 and or 1 to 6 months of imprisonment. And finally, there still should be an emphasis of respecting human rights in doing the surveillance and response activities. Discrimination itself is a prohibited act under this law. So these are some references that I've used, and thank you for listening, and we will have our Q&A session later.